physios, I welcome you all to our channel Physiotherapy. After a long break, I am back in front of you with some amazing new topic. What is it? It is shoulder complex. Till now, we were studying electrotherapy and exercise therapy on our channel. But from today, we are going to start biomechanic lectures. Also, along with it, exercise therapy will be delivered to you at a very good speed. Okay. So, before just starting the biomechanics, I just want you to be prepared with some, we can say you need to brush up your topics regarding the anatomy. Okay. Because if that is good, I will make you master all of these concepts very easily. Okay. So, let's begin the topic. Okay, shoulder complex. What is a shoulder complex? Shoulder complex is a link. It is a link between upper limb and the axial skeleton. Okay, so this is the appendicular skeleton while this is our axial skeleton. So can I say that my shoulder joint is connecting my appendicular skeleton to the axial skeleton? Yes. So we can write it link upper limb to thorax. Okay, and you can write upper limb as the appendicular skeleton while the thorax as axial skeleton. Okay, it is one of the most important joint of our body or one of the most important complex of our body. Yes. Is it more a mobile joint or complex or more we can say stable complex? Yes, definitely it is a very mobile complex. So here mobility is greater than, very greater than stability. Why? Because you know that shoulder joint has various range of motion: flexion, extension, abduction, adduction, medial rotation and lateral rotation. Also their ranges are very high. Okay, that is up to 180 degree. So it is very mobile joint, and due to this high mobility, it have to sacrifice its stability. Okay, so its stability is less. That is why I have written its mobility is greater than the stability. Okay, another important thing, it helps us to do various ADL. Okay, that you all know. Next, joints which are part of shoulder complex. It is sternoclavicular joint. Okay, acromioclavicular joint, glenohumeral joint. So these three are true joints. True joints. Okay, one is sternoclavicular joint. One is sternoclavicular joint. Second is acromioclavicular joint. Acromioclavicular joint. And the third one is glenohumeral joint. Okay, glenohumeral joint. Sternoclavicular is between sternum and clavicular. Acromioclavicular is between acromion and clavicle. Glenohumeral is between glenoid cavity of scapula and the humerus bone. Another important thing. Next is scapulothoracic joint. Scapulothoracic. This is not an anatomical joint. This is not an anatomical joint but a functional joint. Okay, functional joint, and we will discuss it further. Next is subacromial space or suprahumeral space. These two are false joint. False joint. Okay, so these are three true joint and two false joint. Out of these two, this subacromial or suprahumeral joint is now referred to be the subacromial space. It is not a joint, it is a subacromial or suprahumeral space. Okay. Then this is about the joints which we will be dealing in this particular complex. Now bones. Which bones are there? Definitely clavicle. Okay, then scapula. Okay, then sternum. Okay, then we can say humerus, okay, and along with sternum some part of first costal cartilage is also, we can say, part of shoulder complex. So if somebody asks you what number of joints are there, you will say that there are 3 true joints, that is sternoclavicular, acromioclavicular and glenohumeral joints. So these are 3 true joints. 2. Fourth one, scapulothoracic. It is not an anatomical joint but a functional joint. And last is subacromial or suprahumeral joint, which is now referred as subacromial or suprahumeral space, and it is considered to be the part of glenohumeral joint. So this is what I wanted you to understand. Okay, so you can add beautiful comma here. Okay, next. Okay, so this is about the general introduction of the shoulder complex. Okay, now important thing is that due to this very high mobility and less stability, there are a lot of cases in which shoulder joint have various type of injuries, and if we want to properly diagnose and rehabilitate a patient of shoulder joint injury or pathology, we must have a complete biomechanical knowledge of it. So now moving toward the first joint, which is our sternoclavicular joint. So definitely what bones will be involved? Sternum. Okay, and from sternum manubrium sterni. Okay, this part, upper part, and next it is the clavicle. From clavicle it will be the medial or lateral end. Medial end of clavicle will be part, and from the rib first costal cartilage is the part of sternoclavicular joint. And sternoclavicular joint is the only link. It is the only link between upper limb and axial skeleton. Okay, so I said that shoulder complex is acting as a link. Okay, but in shoulder complex there are 3 types of true joint and 2 false joint, and from these, which is the main joint or which is the only joint which is acting as a link between axial skeleton and appendicular skeleton, or acting as a link between thorax and upper limb, it is the sternoclavicular joint. So this will act as a link. Okay, so now we will discuss that what type of joint is the sternoclavicular joint. It is plain synovial joint. But when you studied it in anatomy, you must have studied that it is a saddle joint. It is a saddle joint. It is a saddle joint. But why I am writing it as a plain synovial joint? Okay, what is a saddle joint? Saddle joint is a type of joint in which the 2 articular surfaces are reciprocally concave and convex, such that they fit into each other very congruently. Okay, but here the saddle surfaces, very less, or we can say minute, due to which it do not make a very congruent joint. So in biomechanics we refer it to be a plain synovial joint. Okay, because saddle joint have like this part here is convex and here is concave, and the next surface it will be convex here and concave here, so that it will fit into each other congruently, but here it does not. So the type of joint is plain synovial joint. Okay, now let us move toward the articular surfaces. What will be the articular surfaces? So you can identify this particular bone, one of your favorite bone. This is clavicle bone, and this is a clavicle bone of my left side of left side, not mine actually. Okay, so it is a clavicle which belong to the left side of the body. Okay, now this joint is formed between sternum and clavicle, and from sternum it is the lateral part, that is manubrium sterni, that is the clavicular notch, and from clavicle it is the medial end of clavicle. So what are articular surfaces? It is medial end of clavicle and lateral end of sternum. Okay, like this you can see, and here you need to focus. I will prove that why I write it as plain synovial joint. Okay, here only from the medial end of clavicle only antero-inferior part is making the joint, while posterior-superior part is not making the joint. What does this mean? This means that only the anterior and inferior part of medial end of clavicle is articulating with manubrium sterni and first costal cartilage, while this posterior superior part is not articulating. Now you can see, is it seen to be a congruent joint? No, it is not like a congruent joint. That is why in biomechanics we regard it as a plain synovial joint. Okay, so I explained to you the articular surfaces. Okay, so in articular surfaces you need to understand that only the antero-inferior part is taking part in the articulation, not posterior-superior part. Next is the degree of freedom, which we will discuss later, and just I will tell you there are total 3 degree of freedom, 3 rotatory and 3 translatory. Next we will study after some time. Now discussing about capsule and ligament. Okay, so capsule, there is a fibrous capsule. Okay, there is a fibrous capsule. Okay, fibrous capsule. So before studying capsule and ligament, we will move toward sternoclavicular disc. Sternoclavicular articular disc, which is a special structure present in a sternoclavicular joint. So this disc is a fibrocartilaginous disc, or we can say it is a menisci. Okay. Now what are the points from where it is attached? It is starting from the posterior superior part of medial end of clavicle, and it have its attachment toward manubrium sterni and first costal cartilage. Okay, so it is like this. So this is a fibrocartilaginous disc, and now I will draw the capsule. This is capsule. So now you can see that this disc is dividing the sternoclavicular joint space into 2 parts. This upper part will be the superior-medial part, while this will be inferior-lateral part. This is superior-medial and this is inferior-lateral part. Okay. So this is a special structure. Yes, it is a special structure. So definitely there will be some special function which it is imparting. So as this sternoclavicular articular disc is a special structure, yes, so definitely it will impart some special function. So what are the functions of it? First function is toward stability. Stability. From stability, the stability is by 2 functions. First is it help to increase the congruency. Okay, as the knee joint have menisci to increase the congruency of the articulating surface, here also it help to increase congruency. Second is prevent medial translation of clavicle. Okay, medial translation of clavicle. That is why, so this one is the clavicle. If there will be some medially directing force, it will be moving like this. So it prevents the medial translation. Second is it act as shock absorbent, shock absorber. Also it help to dissipate, medially directing force. Okay, so I am pushing this wall, which is a medially directing force. This disc is dissipating this force. Okay, so which is the third function. Next important function is regarding the motion, and I will explain this by two set of motion. First is elevation and depression. Second is protraction and retraction. During elevation and depression, what I am saying, during the elevation and depression, the disc is stationary. While here during the protraction and retraction, disc is mobile or it is moving. When the disc is stationary, okay, here the part which is acting as a hinge or pivot is upper part of disc, upper, and here it is lower. What I am saying, let I explain. In elevation and depression, the disc is not moving, that is, it is stationary, and if it is stationary, it acts as a part of manubrium. Okay, so this one is manubrium. Okay, elevation, depression, disc is not moving and disc behave like the part of manubrium. But when it is protraction and retraction, disc is also moving and here it behave like the part of clavicle, And during both these movements, either it is elevation and depression or protraction and retraction, disc act as a pivot or hinge around which movement is occurring. But in elevation and depression, upper part is acting as hinge, while protraction and retraction, lower part is acting as hinge. So let us explain this again. During elevation and depression, disc remain stationary. So if it is stationary, it is behaving like a part of manubrium. But in protraction and retraction, disc is also moving, so it is behaving like a part of clavicle. And for both of these movements, disc is acting like a pivot or hinge. But the elevation and depression, the pivot is the upper part, while for the protraction and retraction, pivot or hinge is lower part. So this is what I am trying to explain. So this is whole about the sternoclavicular disc, and now we will be focusing on the capsule and ligament of sternoclavicular joint. Okay, so from the ligaments of the sternoclavicular joint, there are total 3 ligaments. Okay, 3 ligaments. So first one is sternoclavicular ligament, so which is present like this. Okay, attaching from sternum to clavicle, and this is anterior also and this is posterior also. So let me explain that this is the clavicle and this is sternum. This is anterior sternoclavicular and this is posterior sternoclavicular ligament, and its function is very simple. Anterior one will limit the anterior translation, while posterior one will limit the posterior translation of clavicle. Okay, so this is whole about the sternoclavicular ligament. Okay, this is whole about the sternoclavicular ligament. Next, it is the costoclavicular ligament. Which have 2 parts, anterior lamina and posterior lamina. Anterior lamina will move in lateral direction. It will move in lateral direction, while this will move in medial direction. So this one is anterior lamina and this one is the posterior lamina. Okay, this one is the posterior lamina which is moving medially. Okay, so anterior lamina is moving laterally and posterior lamina is moving medially, and whole it is the costoclavicular ligament. And what is its function? You can see it will help to prevent excessive elevation of the clavicle. Also it help to dissipate the superior translating force and also prevent medial translation of clavicle. This one is sternum, this one is clavicle. Here it is attached. Ligament is like this, this finger. So what it will do? It will prevent excessive elevation, also dissipate superior directing force, also prevent the medial translation of clavicle. Okay. Third ligament is interclavicular ligament. It will attach clavicle of this side to the clavicle of other side. So this one is clavicle of left side, this will be of right side. It will connect both of them. And what will be its function? There are two functions. It will prevent excessive depression. Why? Because brachial plexus are passing here, subclavian artery is passing here, and if there will be excessive depression, it can compress these structures and cause various problems. Also it prevent superior translation of clavicle. Okay, so this is whole about the first lecture. Okay, so in our next lecture we will study about this degree of freedom part, that is motion of sternoclavicular joint. So till now what we have studied, let me just recap it. Shoulder complex, it will link the upper limb to thorax, that is axial skeleton is linked to appendicular skeleton. Mobility is very high but stability is low. What are the joint? 3 are true joint, 2 are false joint, and this one is referred to as a space which is a part of glenohumeral joint. Scapulothoracic is not an anatomical joint but a functional joint. What are bones involved? These are the bones. Sternoclavicular joint, what type? It is a plain synovial joint. Why? Because the saddle surfaces are very minute. Then articular surfaces I have explained, it is an incongruent joint. Why? Only antero-inferior part is articulating. Degree of freedom we will discuss in next lecture. Okay, articular disc originate from posterior superior to sternum and manubrium sternum and costal cartilage. Its function along with capsule and ligament. First ligament was sternoclavicular ligament. Sternoclavicular. Anterior one will limit anterior translation. Posterior one will limit posterior translation. Next is the coracoclavicular ligament. Okay. Next is the costoclavicular ligament. Costoclavicular ligament, which is having anterior lamina moving laterally, posterior lamina moving medially. Okay. And what were its function? It will prevent excessive elevation, help to dissipate superior directing force. Okay. Last one is interclavicular ligament. Interclavicular ligament, it will connect the two clavicles, prevent excessive depression and excessive superior translation. This is whole about the first lecture. I wish you all would understand this concept very efficiently. If there is any kind of doubt, please mention it in the comment box. I will reply it as soon as possible. So till then, you keep on studying. Thank you to one and all.